you all for tuning in. Really excited about today's guest, Dr. Husain, Dr. Abid Husain, who is probably one of the most thoughtful and comprehensive thinkers out there in the space of cardiovascular medicine. Dr. Husain is a cardiologist by training, board certified, has been practicing for many, many years in that capacity. And I would say over the last 10 plus years, he's been really approaching it through the lens of cardiology as it intersects with longevity and general health optimization. So he's been working at some of the top practices in the world, doing this, including currently at the Boulder Longevity Institute. He's also a fellow Denverite, like myself. And so he really just brings a real wealth of knowledge about cardiovascular medicine, but also cell biology and systems biology. And I think, as you'll hear today, understanding that intersection is essential to really understanding how we can be more proactive and more effective, frankly, at addressing cardiovascular disease. And so today, we're also going to be launching Dr. Husain's course that he's built in partnership with us. And so if you like what you're hearing from Dr. Husain, if you want to hear more from him, you can scan the code in the top right and check his course out. It is, and obviously I'm biased, but I think it's the best cardiology course I've ever seen or taken. It's just amazing, the level of detail, level of comprehensiveness that's out there. It will, I can guarantee you, it will change your perspective. It'll change your life maybe on how you think about cardiovascular disease. So, well, that being said, let's kind of launch in here. First, Dr. Husain, anything you want to add to that, or I'll just call you Abid because that's what
that's a fantastic introduction. I mean, I wish you could do that for me everywhere. So thank you. Yeah, I appreciate that. That's some kind words. So yeah, thanks, Anand.
Awesome. Well, let's kind of dive into one of the first kind of hot button questions that I think a lot of people have on their minds, which is the question of LDL, right? I think we were all taught in medical school that LDL is causative when it comes to heart disease. It is where almost all of the attention is focused, right? Like when a primary care physician or cardiologist is trying to prevent cardiovascular disease, either primary or secondary, a lot of it, or almost all of it, is focused on optimizing LDL. Yeah. And yet I think we also appreciate that it is not fully telling the story of what causes cardiovascular disease. So maybe just tell us a little bit about how do you think about LDL, and then how do you think about where it sits within the broader picture of heart disease?
So if we take a step back and look at actually what we're measuring when we do most standard lipid panels, what we're looking at is a volume measurement of LDLs. So we're getting a total volume of the LDL in the sample. And that doesn't give us an accurate assessment of what type of cholesterol we have there, because the dialogue started 70 years ago looking at just cholesterol and this obsession with saturated fat. And slowly the target of LDL within a few decades became more apparent in the 80s. And the reason for that could be because, depending on what you believe in, whether it's pharmaceutically driven or not, the pathway was identified, the mevalonate pathway, the enzyme was identified, and so we had a target. We only had one target, and we only had one thing that we could treat, and so that's why there was a focus on LDLs, and we didn't have the nuanced understanding of LDL particle size, small dense particles, the degree of oxidation of those particles. But all we did was look at the volume measurement. And medicine, unfortunately, is slow to evolve. And we use guidelines appropriately, but sometimes those guidelines are also the things that just take so much time to change. And I think that we've been entrenched in this idea of focusing on a singular singular marker for what atherosclerosis is. And after 70 years of research, we know that atherosclerosis is a very complex disease. It is multi-layered, that involves multiple different systems. And to think that one simplified measurement of cholesterol is going to give us an identification or help us identify who's at risk is really myopic. So going more specifically into the LDL, the LDL particle, we want to know how many particles there are, because the number of particles or the ApoB measurement is really what's going to give us the amount of incident damage or incidence of contact that the particle has with the lining of the endothelium. Now we got to take that a step further, because it's not just the number of particles, it's the size of those particles. Particles that are large and buoyant tend to be more benign. Particles that are small and dense are the ones that not only can penetrate in between the lining of the endothelium, but they stay in the system longer. They stay in the blood longer. They're harder to clear. Because they stay in the system longer, they become more prone to oxidation. And then, we have a double insult here. We have a small, dense compound that the body can't really manage, and then it's more prone to becoming oxidized and inflamed and causing plaque. So when we look at just an LDL measurement, that doesn't tell us any of that. It just tells us what the total amount of cholesterol is, and that could be what is distributed in a few large particles or multiple really small, dense ones. And that doesn't even take into account whether those particles are inflamed. So, this is over 20 years of treating patients and looking at who ends up having disease and who doesn't. It's really complex to see, just based on a simple lab measurement. And even a history. Sometimes people that we expect to have really bad disease are scot-free, they're clean. And other times people that we think should be really clean end up having really bad disease. And so clearly, using the singular marker of LDL has not been able to stratify that well enough. Maybe on a population standpoint, but that's probably arguable too. I mean, we know that Mendelian studies show that, population studies show that there is an association, but we also know that we're treating people probably aggressively. We're probably over-treating, and that's why the outcomes data for a lot of these lipid-lowering trials, statin trials, is not as robust as we've expected.
Yeah, I think that's very well said, and I think that's, hopefully everyone just fully let that sink in, because I think that is how you can make sense of this, very, very noisy debate that happens on social media about LDL and heart disease and cholesterol and heart disease. And I think a lot of it, in my opinion, is just lost in the noise of people trying to, gain attention, gain clicks, and take these kind of extreme positions that ultimately create these tribalistic perspectives. When in fact, I think there is a lot of merit to measuring LDL and trying to optimize it. But at the same time, we can't rest our laurels on that alone, right? Like we have to look more broadly. And so I think you've kind of hinted at a couple of those things, right? Like you mentioned LDL certainly being a major, major factor. You mentioned particle size. What are some other things that people should be thinking about as it relates to cardiovascular disease?
So we got to look at particle size. So LDLs, particle size, the number of particles, and then what's associated with that. Is there metabolic disease? Do we have insulin dysregulation? Do we have glucose elevations or even drops that are not being detected? In addition to that, we got to look at inflammatory issues. Is there some other underlying inflammatory condition that we haven't been able to diagnose, or is it that there is associated inflammatory issues that are from vascular dysfunction, from metabolic dysfunction? When we start layering those and you get a low grade elevation of inflammatory markers, you get low grade hepatic dysfunction because you've been running a higher triglyceride level, you've been running a higher glucose level, and we start taxing the liver a little bit. We start getting a little fatty liver disease deposition. These things start overlapping and creating a stacked risk that makes the LDL that before may not have been problematic now starts to become more oxidized, more problematic. Add in hormonal dysfunction, where we start to see a drop in, say, testosterone and estradiol. that then we have loss of resilience of the endothelial lining. We have loss of enos, or endothelial nitric oxide function. And then, if we have hypertension added onto that, vascular dysfunction, the glycocalyx starts to get denuded. This is something, even blood sugar abnormalities will start to denude the glycocalyx, and that's dynamic. It will ebb and flow. We start to get a lower amount of that on a steady basis. This is also another additive factor. So, this is a multi-system approach again. This is a multi-system disruption that's leading to atherosclerosis. And so the obsession with just LDL, yes, we want to keep things simple. I think humans don't appreciate complexity. We want things to be simple and have simplified answers. But this is not one of those things where we can just keep simplifying it down to let's lower the LDL. We have maybe in 1980, when we had one tool, that was sensible, and we could say, okay, that's the only thing we can do. But in this era, we have so many different tools, and to continue to simply focus on just lowering the LDLs just seems really naive. Even the current lipid guidelines that came out, they're recommending even lower LDLs. Now, the studies that they're citing say we get stabilization of plaque around an LDL of 55. That may be reasonable if you have a high risk. If you have a high risk patient with a lot of plaque, that's probably a good idea. All right, that fits many decades of guidelines. But do we do that for primary prevention? I doubt it. I don't think so. And it really discounts all of what we've been talking about. It discounts looking at the full system. And I think it also, it does a disservice to medicine, because we're trying to keep things siloed. We have a reductionist thinking, when really you need to think about a patient globally. Like if there is a multi-system issue, then there's other organs that are going to be affected, and that's improving general health. That's improving longevity. So, I think that we have to shift our thinking from reductionist and siloed treatment, which is what it's been, and it hasn't served this, the population well.
Yeah. So I think there's a lot to unpack there, but I think maybe the best way to do that is I want to give you kind of an example case that I think also touches on one of these controversy points, right? Which, this guy, Nick Norwitz.
Yeah.
He is kind of a big advocate for the ketogenic diet and kind of a high fat, low carb diet. And he has a very, I don't know exactly what it is, but a very high LDL and a very high total cholesterol.
Yeah.
And he makes this claim that, quote unquote, metabolically healthy people can just let these things ride high and you don't really need to worry about it. I may be like missing some nuance in what I'm sure he would, knowing him, I'm sure he would say I'm missing a nuance.
Yeah.
But I'm just, the case that I would present to you is like, if you were his cardiologist, or if you were his patient, how would you advise him? Like, what would you advise him to do with that?
Well, I think Nick has gone back and forth. I think in the beginning there was a real effort to stay with the ketogenic diet and not be as focused on the LDLs. And I think, and there was the CTA study that he did, which looked at lean mass hyper responders for a short period of time. His LDLs were significantly elevated. I mean, and total cholesterol also. I think it went as high as into the 700s, something absurd. Yeah. He's a lean mass hyper responder, and those patients can probably tolerate a higher LDL, but I think the reality is that what is the age that this person is functioning at? What is his physiology functioning at? The physiology of somebody that is at that age and can burn through that type of LDL more rapidly, more readily, is not gonna last as we start to go into hormonal decline, as we go into physiologic decline. So, right now in his youth, that's fine. And I would say, we monitor him and treat the rest of the system. Treat all of the things that are around that contribute to vascular health. Make sure he's got the right nitric oxide precursors. Make sure his vascular endothelium is well supplied. Make sure his other risk factors in inflammation are controlled. If we do that and monitor his potential progression for plaque, then I say, okay, we don't need to be as aggressive with the lipid reduction. When you look at the lean mass hyperresponders, they go to a fully ketogenic diet, and that skyrockets their LDLs. But introducing some carbs actually brings it down in a more benign way than having to introduce any sort of pharmacologics. So it's, I wouldn't say it's holistic, but it's a more systemically appropriate way. Getting a little more carbs into the system helps the LDLs drop a little bit. It's in a more manageable range, and then follow these guys and see if they start developing plaque. And if they don't, or when their physiology starts to show some compromise, then give them the things that would prevent it from plaque from building up. And that would be hormone replacement. That would be the right precursors. Maybe using medications that help the endothelium. So if someone is determined to not be on a statin, and seeing somebody that would have an LDL in that range, that would probably make me scared. But after having a dialogue with them and seeing what their comfort range is, then I would probably treat them without lowering it, progressive monitoring, and that can be done in many different ways. You could do that with carotid intermedial thickness. You could do it with a CTA, and you could do it steadily not annually. It would be over the course of every few years. But someone that's young, that has good muscle mass and metabolically intact or metabolically healthy, they can probably manage a lot of that LDL.
Yeah, I mean, so my thought on it, and I think I think about it very similarly. I would say we have to isolate some of the things that are true of him from what might be true of someone generally who might have a metabolic profile, a cardiometabolic profile like that.
Mm-hmm.
Because there's a lot of people who listen to him who are very unlike him, right? Who do not have his youth, do not have his other factors. And I think for those people, and again, thinking holistically, right? It is true that LDL and ApoB are not the only piece of the picture, but they are still a part of the picture. I think there are some people who want to almost make it seem like it's not part of the picture, which I think is, in my opinion, also a little bit foolhardy, in my opinion.
Yeah.
My perspective is, if you don't have some kind of, dogmatic belief about having it that high, or I can't have statins or something like that. I think in his case, at this point, his image is tied to this. So I think there's probably some material economic loss. If he actually were to try to lower his LDL with even a PCSK9 inhibitor, I'm sure some of his followers would be like, oh, what happened? And then he loses. Anyway, it's not my place to judge any of that. But I think the point is that it's all about balance, right?
Yeah.
And I think, as you said, if I were his physician, I would get nervous about something like that. And I'd be like, well, why can't we try to do something about this, and not necessarily bring it down to 10 or 20 or something like that, right? But instead, just let's bring it down a little bit, right? Let's try and just make the system more in balance.
Well,
right?
If we look at it from a cell biology standpoint, okay, we know that the argument is that lowering your LDLs too much impairs your membrane dynamics, impairs membrane health. And so why is that important? The membrane is where we have these lipid rafts, and these lipid rafts are how the cell communicates with itself, with the immune system, how it transmits messaging, and membrane fluidity is how the cell stays healthy. Okay, we've seen that experimentally. How does that show up in clinical outcomes? This is a new science. We don't know. And it's a very subtle thing. We don't really know what we're looking at to look at clinical outcomes. So we're basing that on experimental science. Let's say we take that for dogma and we believe in that. The contrary to that has got to be true also, because that's how nature works. We have a balance. One, we don't work on extremes. We work in the middle. We work in a balance. So if we have extremely elevated lipids, then what happens? Then we get lipotoxicity. Then we get stiffening and we get loss of resilience of the membrane. So swinging from one end to the other is unhealthy also. So when you have LDLs in that range, if you have it's going to cause a problem. It's going to cause inflammation. It's going to cause stiffening of the membrane. It's going to cause loss of transduction, maybe even increased inflammation. It may not show up now. It may not show up in 5 years, just like the other side of the coin where lipids being too low may not show up now or in 5 years, but eventually there will be something that shows up and we won't know exactly what it is that to look for. So, prudence would dictate keeping him in the middle and keeping that type of cholesterol better managed. That's we're looking at lipid dynamics and physiology in really a completely new way right now. So a lot of these are answers that we're not going to have, but we still have to consider what we've seen in the past. Too low is never a great idea. Neither is too high. So, and I think I don't know what he's thinking, but based on what I've seen in recent interviews and recent podcasts or recent broadcasts, he is sort of rethinking that on a smaller scale. He's actually adopting anti-lipid therapy, but he's saying it's for his ApoE genotype and for brain health and for some studies that say it's positive for neurologic health. So, whatever the reason is, there is a swing back and forth, and I think it's going to land somewhere in the middle.
I think that's well said. Well said. I just want to ask you briefly about something that you mentioned earlier from a mechanistic perspective. You had said that for people who are on very, very low carb, high fat diets, reintroduction of carbs can help to bring the LDL or ApoB counts down. Do you have a sense mechanistically of how that might be happening or why that happens?
Well, it's particular to the lean mass hyperresponders. When we see a standard, more average physiology, and we introduce a little bit of carbs, I think it does bring the LDLs back down a little bit. My guess is that that's probably because we're introducing a little bit more triglyceride. The triglyceride then there's a balance of triglyceride and cholesterol in the LDL particle. And so if we remove the triglyceride, then it becomes saturated with just LDLs or just cholesterol. There's no capacity to remove much of the triglycerides, and your triglycerides stay very low. That changes the volume of cholesterol is being measured and the dynamics. As it goes from a VLDL to an LDL, what we're doing is we're removing a lot of the triglycerides along the way. If that's not there, then what you start out with as a VLDL doesn't really change too much, and we're saturated with cholesterol. If we reintroduce a little bit of triglyceride, I think it maybe it influences some of the lipid dynamics so that we can transfer a little bit back out and changes some of the size of those LDL particles.
That makes sense. Let me shift gears now to measurement. You kind of hinted before at some different tests that people can do to measure cardiovascular disease. I'm curious, I think in my opinion, you can kind of put these in two different buckets, right? Like there are these risk measurements, which include certainly ApoB and LDL, Lp(a), other kind of blood-based markers. And then we have kind of more direct measurements of disease progression itself, which would include the CIMT, coronary CTA, calcium score, and so on. So I'm curious, like, what's your framework for thinking about testing, and when should you use what tests for which patients?
Yeah. In a perfect world, I would be getting carotid and coronary imaging. The reason is because I don't want to necessarily do coronary imaging frequently. The most frequently I'll ever do it is maybe the first couple of years in a high risk patient. But the ideal way would be get a CCTA of the coronaries, as well as a carotid intimomedial thickness or kind of carotid ultrasound, one that can really isolate the amount of plaque down to the percentage. Now, the carotid is going to be more operator dependent, but if you get a good place to do it, you can continue to use that place and get serial measurements. So one is to assess assess presence of disease, assess presence disease in the coronary arteries. Now, the studies show, and historically, there should be a correlation between the coronary arteries and the carotids. The flow dynamics are very similar, and location very close. Pressure is very similar, so they behave very similar. Ideally, we see an equivalent amount of plaque in the coronaries and in the carotids. So if we can make that association, then we can do more shorter term or regular follow-up with the carotid and see response to therapy. So, and it saves me a little bit of repeat testing and on an annual basis. So you could do a carotid intimomedial thickness, look at response to therapy as the intima starts to narrow more, because that's what we want. We want to go from a thick, sort of inflamed intima to a less inflamed, more narrow, stable intima. That's a sign of positive response to therapy. And then you can also see sometimes soft plaque regression in the carotid. So that will save you from having to do a repeat CCTA in short order, and it also gives us another data point. If you don't have a carotid intimomedial thickness, then you got to use the CCTA. And the reason why I do both of those when I can to start out is because sometimes there is a discrepancy between the carotid and the coronaries. You may have more here than in the neck, and vice versa. So we want to establish coherence, something that correlates the amount of disease, and then a mechanism or a method that has low radiation to do follow-up testing. That's easy to do. A carotid ultrasound is low cost and no radiation really. So if you wanted to give the patient a way to feel reassured that we're doing something that's working, you could potentially do it at 6 months. I think annually is probably the best way.
Got it. And so as far as the coronary CTAs, I know that there's several different kind of technologies that are out there. I think probably the most well-known one is Clearly.
Yeah.
There's other companies that have now come out with technology. How do you think about the differences between these providers, and also if there are any caveats or things to be aware of, right, when you use these? Because at this point you've had a lot of experience using these over the years, and as these become more popular, there are going to be things that come up that may affect the disposition of the patient. So curious to hear your thoughts on this.
I stratify them in symptoms first. If you have somebody that's got chest pain, then Clearly is useful, but it may not be the best test. You may want to do a heart flow. So the difference is Clearly looks at the images, looks at the pixels, and refines those pixels, refines the data that you get from the pixels to image or recreate plaque biology. Heart flow looks at, it uses the images to approximate flow. And so the difference is when you have lesions that are probably above 50%, those are the lesions that we start to question whether there's ischemia. So heart flow has a larger market share because it's used in hospital settings. It's when the CCTA is done in the ER for somebody that's got chest pain. If there is ischemia, then they're going to know much more definitively before going to the cath lab where the ischemia is, and they'll have a validation for needing to put a stent in. So if they have to do, a flow measurement in the coronary artery, that's how it was done in the past with a flow wire. Maybe they don't even need to do that anymore. They'll go in, be targeted, do the procedure, and get out. So very useful in a symptomatic patient to determine if they have ischemia or not. That's not generally our population. If it's symptomatic, they're going to be seeing the cardiologist, they're going to go to the ER. That's somebody that we don't really see in the longevity sector. In the outpatient longevity sector, for prevention and for health optimization, clearly tends to be better, in my opinion. This is because we get better visualization of plaque dynamics, and then it's more specific about the pixels, and we get a lot more of the details. I mean, that being said, they both have comparable technology now. HeartFlow does have a plaque add-on, so you can use that with HeartFlow, and clearly has now added a flow aspect to it as well. But I think that clearly has got a better database. That's the one that's more easily available as an outpatient, and I think it might even be a little bit cheaper. I'm not sure about that, but so those are the two main ones. There's a third company that is just starting to be available in the States. That's called Carry Heart, and they have a similar type of technology, but what they're adding is vascular inflammation. So they're adding the potential to look at inflammation from a fat inflammation standpoint. What do we do with that? I mean, there's anti-inflammatory therapies that you could add on, but it still hasn't been completely rolled out. So maybe look out for that. But right now we're talking about Clearly and HeartFlow. So in a preventative sort of longevity mindset, I would say you get a Clearly, establish their plaque burden, and that can dictate what type of therapy they're gonna need to be on. Whether it's low intensity therapy, do they even need therapy? Do they need lipid reduction? Is it are there lipid levels? Are there lipid levels causing plaque more or less than expected? And then we get data on inflammatory plaque. Is there inflammatory plaque? And if there is, then that's add-on therapy. Consider anti-inflammatory therapies like colchicine. Maybe we add on higher level vascular control therapies. And there are some issues with CCTA. It's not perfect. This is probably the second generation of this technology. And same thing with these AI platforms. It's just still pretty new. And so we can't take percentages of stenosis for face value. Oftentimes it requires looking at the actual images and seeing if there really is a stenosis, or is this something that is an error for the computer in how it's making the contours in the arteries. So having experience looking at catheterizations and being in the cath lab for many years, it's helped me to understand that sometimes the way the computer is assessing stenosis may not be as accurate as we think it is. So that's one issue with CCTA. And the other issue is studies where they've taken the same disk, loaded it into the same CCTA based AI processing, and they get some different measurements, or it will drift to worsening plaque. And it might be a small drift, it might be minimal, but if you're doing sequential measurements, you kind of have to keep that in mind. Like, even if there's a minor increase in plaque, this may be within margin of error, and this is not a perfect science. We've got to kind of take a step back and calm ourselves as well as patients down to realize that if there is a small amount of increase, that may actually not be as much of an increase as we think it is.
Got it. Got it. And I think you may have addressed this, but there's a question that just came in about Caristo's Carry Heart FAI scan. Is that what you were referring to?
Yeah, that's what I was referring to. They are available in the States. They have a similar plaque biology report and an aspect to them. Also flow dynamics. But what they're going to have is a inflammatory add-on, an inflammatory report, which tells us about how much inflammation is actually in the endothelium and potentially in the intima where there's adipose tissue, fat tissue, lipid, and inflammation is based off of that.
So, of course, we all know that cardiovascular disease is the number one killer here in the United States, and this is true in most of the world at this point. And so, I think one natural next question, given all the advances you've highlighted in early detection, is age. At what point should we start implementing some of these advanced imaging-based screening methods? I mean, I think at this point, most people are now getting the basic lipid panels through their primary care, but I think these more direct measurements, I do wonder, like, at what age would you personally recommend people start getting screened? And I'm just for sake of specificity, let's assume this is a person who doesn't have any family history. They're just an average person. When do you think it makes sense to start initiating this type of screening?
This is not guideline based. I mean, based on where we see most of the acute, when we see sudden cardiac death, it's in the young population. It's the population that gets missed. So, screening ideally would be by 40 years old, maybe at 40 to 45. We're doing colonoscopies at that age, 45 years old now. We should be doing a CCTA around that age because this is a preventable disease. This is something that if we detect somebody that's got, significant amount of soft plaque early, we have tools to be able to change that. We have tools to be able to institute reversal of plaque, and there's no reason why we can't save those people early on. So, that it's aggressive, but I think that's it's important to get that data up front early.
Yeah. Related question that somebody just asked: have you ever seen with the Carry Heart an increased inflammation score, but no plaque on CCTA? And do you have a framework around how to manage those sorts of patients?
Yeah, the belief is that's early inflammatory disease. Maybe it's early vascular inflammation. So how do you manage that? You look at what's going on metabolically that could be influencing it. Are there other inflammatory sources? Give the endothelium the foundational support it needs, meaning the right precursors. Make sure there's not endothelial uncoupling. Like we got to see what's causing the inflammation. Start from the ground up. See what the basic metabolism looks like. Do they have the right hormonal health? Do they have the right precursors? Are they eating well? Are they exercising? And then if that's all in place, then we start supplementing them and giving them what they need. If that's also in place, then we scale it up. Consider a GLP-1. Then we look at statins. We look at PCSK9s. I mean, it helps to scale up therapy depending on where they're coming to us from, because the early onset of plaque is inflammation in that vascular endothelium.
So you kind of touched on where I wanted to go next, which were therapeutics, right? And I think what I want to focus on, rather than focus on lipid lowering therapies, where I think there's been lots and lots of coverage and attention on certainly statins, but even more recently PCSK9 inhibitors, are some of these adjuncts that touch on some of the other aspects of the systems biology of cardiology. And so I want to start with one that you just mentioned, which are GLP-1s. I mean, certainly, I think we can appreciate how GLP-1s can help reduce blood sugar and reduce the risk associated with with poor glycemic control. But I'm curious, do you use GLP-1s to manage cardiovascular risk, even in somebody who maybe doesn't have wildly out of control diabetes? Or how do you generally think about the role of GLP-1s in cardiovascular prevention, given their highly diverse and pleiotropic effects?
Mm-hmm. So in my mind, the atherosclerosis is a metabolic disease. And so we should be treating it appropriately with metabolic agents. GLP-1s are ideal agents for that sort of for that mindset of treatment. When we look at what it is GLP-1s do outside of weight loss and glucose, they help increase nitric oxide. They reduce the inflammatory markers like NF-kappa beta, I think the IL-6, other cytokines, and then they also reduce adhesion molecules on the endothelial lining. So that combination, as well as having a mild effect on some of the lipids, shows in experimental studies, and this is, I mean, granted, these are rat models, but when you look at the experimental studies and what we see observationally, we can connect the dots that we do see some evidence of plaque regression, some plaque stabilization, reduction in vascular tension, and maybe even improved nitric oxide availability, vascular flexibility. So there's a lot that this does outside of glucose control and weight loss. When you add in fat reduction of the adipose tissue related cytokines, reduction of the end glycation products and glucose dysregulation. This is potentially a really useful and game changing therapy that most cardiac patients should be on. And to answer your question, it's one of the key foundational therapies that I use. Even if their weight is normal, if their glucose is well controlled, I will use GLP-1s at a low dose to manage vascular health. Now, the common question is, well, if the dose is so low, is it really doing anything? I think it is. Now, the reason is because you're using a medication that's got a much longer lifespan to it. GLP-1 that's endogenous only is secreted for 20 minutes after we eat. So that's the only time we get exposure to GLP-1 without pharmacologic assistance. At low dose, you're getting a much larger area under the curve, even with low dose GLP-1 stimulation. So there's got to be an accumulation of time with the positive metabolic benefits, positive vascular benefits. And so even low dose therapy, I think, has vascular benefits.
And so when you say low dose therapy, I'm curious, what dose and which agent do you prefer to use?
The agent I prefer right now, my preferred agent is tirzepatide, mostly because the side effect profile is low, easier to titrate it because we're using higher milligrams. And low dose is really individualized. Depends on where we find that balance where we're getting not as much appetite suppression. If we need appetite suppression, then I titrate it up. If I don't, I bring it down and do it just below appetite suppression, and that also mitigates some of the side effects. So, I mean, that for most people, 2.5 milligrams. 2.5 or a little lower, but 2.5 is usually the starting point, and we kind of adjust from there.
Got it. Very interesting. Yeah, I mean, I think we continue to be. Let me just ask you a non-cardiology related question, right? Because I just on the topic of GLP-1s, which are so interesting and so important increasingly. I'm curious, is there ever a situation where you wouldn't want to use a GLP-1? And I'm like, I want to set aside the whole like muscle mass thing, which I think you and I can both appreciate is more of a second order effect, right? Where people are not consuming enough protein, not doing a lot of the other lifestyle related interventions. But, I really sometimes try to rack my brain around like when like I compare it to something like rapamycin, right? Where like I can think very clearly of many scenarios where rapamycin, I wouldn't want to use it. In fact, I probably don't use it that much anymore, except for older people.
Hmm.
I think with GLP-1s, and again, I promise I have no affiliation with any company that's making GLP-1s, but I really do sometimes. I'm like, man, like when would you not want to use one of these?
Yeah.
So I'm curious, like, how do you think about that? I think like use that maybe as like a way to kind of talk about systems biology as it relates to all this. But I'm curious,
Yeah.
what's your take on that?
I usually reserve it. I won't use it in really lean people because I think that they tend to have more side effects with it, and there's a much smaller window of tolerance for them. I also don't use it in people that have bowel issues, meaning if they have already existing constipation, they have some sort of ileus, they have some sort of slow bowel movement that I have not been able to solve, then I don't use it on them. And who else? I will probably, if there's a history of pancreatitis, I'm very cautious.
Mm-hmm.
But we will monitor it and use it at low doses. The thyroid cancer issue is not really, I think, as much of an issue that it's
Mm-hmm.
that needs that I use as a contraindication. If they have active thyroid cancer, then I think it's probably prudent not to. But otherwise, if it's something that's been treated, it's in remission, or they've had surgery, then I'm comfortable doing it.
Got it. Let me switch gears and talk about another agent that gets brought up in this kind of adjunctive cardiovascular prevention conversation, which is sildenafil and
Hmm.
tadalafil and kind of
Yeah.
PDE5 inhibitors. What are
Hmm.
your thoughts on those?
I think that those are fantastic agents for optimizing vascular health. Um, you know, uh, Daily low dose tadalafil. I often use that in men and women for optimization of nitric oxide. There was a like a really a powerful study that flew under the radar, and I forgot the exact. I think it was maybe 2 years ago it came out. It looked at low dose tadalafil, 2.5 to 5 milligrams, I think was the dose, over a wide range of the population. And it showed almost, I think, a 30% drop in all cause mortality and cardiovascular events. Really substantial. And, you don't see those kinds of outcomes with any of the lipid lowering agents, with statins, with PCSK9s. So this was a dramatic benefit, and this is one of the studies that I think outlines really well, actually spotlights the benefits of using something like a PDE5 inhibitor at low dose for the right patient to optimize their vascular health. I mean, what we're doing is we're improving the ability for vascular dilation, optimizing the nitric oxide that's there, being able to make more, use that in conjunction with hormone therapy because testosterone amplifies the ability of PDE5 inhibitors. So you can really get some much better global blood flow with that.
Interesting. Let me put in two questions here that just came in. I think they're both related to biomarkers, but how reliable are HSCRP and PLAC as a proxy for coronary vascular inflammation? This person says that they've heard mixed opinions about
Mhm.
PLAC or plaque. And then related to another biomarker, LP little a, do you use the LPA guidance calculator, which is based in the UK Biobank, kind of for risk prediction? So questions about HSCRP, PLAC, and LP little a.
Yeah. What I've been doing over the past few years is trying to put together a framework for people to use to understand how to interpret it, to utilize the biomarkers in day-to-day practice. HSCRP has got some of the most data supporting it. It's a non-specific marker. It's going to tell us. It's going to give us an association, but there's a lot of room for error in using HSCRP alone. It can be used as a initial determining factor of whether somebody's got inflammatory disease, but you've got to get some serial measurements because an isolated CRP can sometimes be a short-term elevation. It's a short-term inflammatory marker. So we need to get a few others that are longer term. the plaque score is, the PLAC or LPPLA2. It tends to be an enzyme that's in the vascular wall, and it is amplified, or it's turned up, activated by high carbohydrate diet, smoking, inactivity, and LDLs themselves. So LDL itself can drive LPPLA activity. So, and what is that? It drives the LPPLA when it's elevated, sometimes drives oxidized LDL. That's the assumption. It's changing LDL into oxidized LDL. Sometimes that doesn't necessarily show up in lab markers, but it does tell us that the system is reacting to LDLs in some way. It tells us that if the lifestyles, it can be an indicator of adherence to the right lifestyle. And if that is out of the picture, if we know that they are, then it can give us an indicator of LDL effect on the vascular wall. It doesn't necessarily mean that there's going to be plaque, but it means that there's something metabolically active, and it needs to, and something to be aware of. If we take that one step further and look at oxidized LDL, if we see LPPLA2 elevated and oxidized LDL, then we definitely know that high LDL is causing downstream vascular inflammation and potentially plaque. The absence of oxidized LDL doesn't necessarily mean that, but if it's there, it definitely means that, because oxidized LDL tends to concentrate in the plaque up to 70 times more, and it may still be absent in the serum, even though we have it in the plaque. So, there is some nuance there, and I try to go over all of that in the course so that you can kind of take these biomarker panels, tease it apart, and make sense of it, so that and then make clinical decisions with treatment on a day-to-day basis.
Awesome. Well, thank you so much. Super thorough there. Let me just ask you. Go ahead.
The LP(a) question.
Oh yeah, LP(a). Yeah, please.
I'm not familiar with the UK database. My belief about LP(a) is that it is a risk amplifier, and if we there's plenty of people that have LP(a) elevations that don't have premature disease. And so I think that those are the people that end up having other risk factors well mitigated and well controlled, and the system is able to manage LP(a), the LP(a) risk and predispositions. So I'll have to familiarize myself with that database.
Got it. Let me kind of ask you one last question, and then we can wrap up as we're close to the top of the hour here. You mentioned testosterone, right, as being beneficial for cardiovascular health, and I think that flies in the face of a lot of what we were taught about testosterone. In fact, in the past, we were often instructed, as you know, to consider cardiovascular disease or cardiovascular risk as a contraindication to testosterone.
Yeah.
And so tell us a little bit more about that. Like, number one, why did this finding arise? Why did we have this warning in the first place? And then why do you believe that to be not the truth?
Yeah. I think it's a combination of three really bad studies and the confabulation of bodybuilders with physiologic testosterone replacement therapy. So testosterone was being used by bodybuilders for in cycles that are probably 10 times higher than what we would consider using clinically. Those patients, those athletes and bodybuilders had LVH, they had hypertension, they had premature atherosclerosis. They were using doses that were way too high, and they were using it in conjunction with anabolic steroids. Anabolic steroids reduce HDLs and increase your LDLs. So we're talking about a population that was much more amplified and tuned to be making atherosclerotic plaque. That population was used as a template for the assumption that high testosterone or testosterone therapy can cause plaque. I think there was also an old belief that the reason why men had heart disease earlier than women was because of testosterone. And we know that that's not the case now. We know that it's actually estrogen's protective effect that kept that from happening. So we have that leading into an environment where there were 3 studies that weren't even looking at cardiovascular outcomes, but had that as a secondary potential outcome of the trial. And in 2 of those trials, it wasn't even accurately being translated. Like, they completely misinterpreted the data and decided that they wanted to call it increased cardiovascular risk with the use of testosterone. 2 of those studies were retracted by the authors. The one that remained, I think it's the Finkel study, is largely, I think even the FDA has discounted that study, and this is why the FDA went, in last year, took the cardiovascular risk warning off of testosterone. So you've got a convergence of medical myth, confabulation, and bad studies, all telling us that testosterone potentially has bad cardiovascular outcomes, when the reality is that over 100 years of data, we've seen that testosterone improves cardiovascular events. People that have low testosterone end up having higher cardiovascular events and worse outcomes. So if we replace it physiologically, we know that we're gonna provide benefit. This is being shown with experimental studies. Looking at experimental studies, we see that testosterone has the ability to improve endothelial cell health, endothelial cell progenitor cells, improve nitric oxide, it's a general statement, but it's anti-inflammatory. So it reduces the inflammatory cytokines. And these are all the direct effects of testosterone. When we look at what it does to muscle health, when we look at what it does to body composition, that's a secondary effect to help reduce glucose excursions, reduce cytokines from fat tissue. So, I think it's largely misunderstood because of a lot of medical myth and fear. And if you have somebody, when I see somebody that's coming in after a cardiac event and their testosterone is in the 300s of total and their free is in the single digits, this is somebody that I'm putting on testosterone, even if it's immediately after an event, because I know that all of the data supports its use and the body does need it. I mean, every cell except for the sperm and the ova have receptors for testosterone. So I guess just think about that. There's a reason for that.
Yeah, no, I think I love what you said about the confabulation, because I think so many people equate testosterone with anabolic steroids, right? And I can even see like somebody cheekily kind of clipping this video and saying, hey, this bro cardiologist just recommended steroids to prevent heart disease or something like that. There's all these reductionist and simplified ways of thinking about things that I think just do not reflect the actual systems biology of all of this, which is what you and I are both passionate about, understanding things through the lens of. And so that is I think super, super interesting. And I think the anti-inflammatory capabilities of testosterone, I think, are increasingly, going to be appreciated. I mean, just to state another thing, right? Why is it that women seem to have such a higher incidence of autoimmune disease? I mean, one of the leading hypotheses is that testosterone and its anti-inflammatory effects are not present for women in
That's right.
same amounts. And so it's super interesting.
There's plenty of case reports of autoimmune conditions that get treated with high dose testosterone therapy. So they're there, and there's plenty of studies to validate it.
Very, very interesting. Well, look, we could go on for another hour, I'm sure. Hopefully all of you guys listening can appreciate just what a wealth of knowledge Dr. Husain has in medicine in general, but especially as it relates to cardiovascular disease. And if any of this felt valuable to you, again, I highly, highly recommend you guys check out the course that he's just created. You can scan the QR code or go to nextgenerationmedicine.co/expert-courses to check out his course. It is exceptional. And honestly, Abid, I'd love to do another one of these very soon, because I think there's so many other nuances we could get into. So thank you so much for taking some
Yeah,
time.
thanks for having me. I appreciate being on here, and I really enjoyed putting the course together. It's much more organized and it's got a framework. On camera, I tend to just vomit out everything I know. So, this is a much more organized way to interpret what I'm trying to tell you. So, um, yeah, thanks for the opportunity, and yeah, I'd love to come back again.
Awesome.